Thank you very much for the organizers. Thank you, Samantha. And thank you all of you for being here. I have to say that you are the motor of our clinics. You are the motor of our labs. And actually, we wouldn't function without all the energy that we get from you. So we are here for you, we live for you, and we root for you. I thought this morning, oh, and before I forget, it's very nice to see you without a blue gown, okay? Well, it's being recorded, I have to remind myself of that. All right, so I thought, I didn't know exactly what kind of constellation of talk would you be expecting, so I thought I'd put a mixed up of things that might be very interesting for you. So I'm gonna go back to the surface, to the clinical appearance, and then I'm gonna dig into the very basic science that we do in our labs, okay? With a population as we have in this room, I don't think I have to go through the ABCDs. You know that very well, okay? With the asymmetry and the border, the color, and all these diameters and evolution of molds and nevi, etc., that you all expect to see. As Rob was mentioning at the very beginning of this morning, melanoma appears in very many forms, okay? And it is something that I want you to remember is that the devil never sleeps, okay? Melanoma comes in surprising manners. So before I show you some very interesting cases of melanoma in very weird appearances, I just want to go through this relative risk that I get asked very commonly in clinics, right? So the more nevi you have, obviously, the more relative risk you get to have melanoma. If you have red hair, you have 15% and nevi, 15% more of relative risk to get melanoma. This plastic nevi, this means weird moles, you know very well, also increases your risk. Sunbed use, we talk about today how melanoma is increasing in young females for the sunbed use, increases your risk as well, etc. So then we have the familial melanoma. I don't see that very often, thank God, okay? There are mutations in a gene called CDKN2A that increase the melanoma risk to 80% if it is given in the family. Okay, so I'm going to present a case. I'm going to present 3 cases of melanoma that appear in a very surprising manner, okay? So this is a 56-year-old female that noticed a shock of brown hair appearing in the middle of the head from the vertex. Out of the blue, she has gray hair. And this appears like years prior to the presentation of the melanoma. And she told the husband, honey, look, I mean, I'm getting younger, getting brown hair out of the blue. And because she went to the dermatologist or to the primary care physician, and they look at the scalp, they look very careful at the scalp, didn't see anything. It didn't occur to them to do a biopsy where the hair was coming. Okay. 6 months before she came to our clinics, she already had a ulcerated black plaque on the area where the brown hair was growing. So now she has a stage 4 melanoma. Okay, this is one of the photos that we did in clinics. This was when she came to us, okay? So this is obviously very weird presentation of melanoma. It doesn't happen very often, okay? But the reason why I'm showing this case is because we used to say, if you are fair, if you have Irish Scottish ancestry, if you have gotten sunburns when you were a child, come to see a dermatologist. I don't say that anymore in my clinics or in our website. I say everyone is a skin check period once a year, at least. We check the hair, you know how nosy we are, okay? The nails, we check everywhere because the devil never sleeps, okay? So this was the pathology. And then we start digging in the literature, okay? Because I haven't seen it. I didn't see it when I was a resident. I had talked to other colleagues and they didn't know, but then we saw in the literature that there were previously reported cases like this one, right? For example, repigmented hair overlying melanoma in situ, okay? This was reported in 2014. See this gentleman out of the blue getting a bunch of curly brown hair in the middle of the head. Okay, this was also a melanoma of the scalp. And other cases, so there are like, our case is the fourth in the literature, practically, okay? So fortunately, in UCSF come many patients from all over the world and over the States, so we are fortunate to be able also to spread the word on these weird presentations that appear to the clinic. The bad part of this presentation is that obviously the prognosis is worse because when the patients come to us, they're already in a very advanced stage because these have sometimes years until this melanoma comes to the surface, okay? All right. Second case, also a very interesting presentation, and I have to say, we all physicians are, we also do, we have to work with lawyers when there are cases that end up in court, okay, unfortunately. Okay. Nail, very commonly missed melanomas as well, okay? This was diagnosed as a habit tick deformity, okay? So when you come to my clinics, many times I touch your nails, okay? And if you have nail lack, a lot of times I will ask you to remove it, all right? My young female patients don't like that, but we are heartless, okay? So this was diagnosed as a habit tick deformity, and so, but it was only one nail. So one nail, habit tick, you know, just think about it. When you have a tick, usually it's not just one nail. When you bite your nails, you don't bite one nail, you bite all of them. I tell you because I bite my nails, okay, when I'm nervous. So this melanoma got also missed many years, okay? Fungal infection, okay, you know how many fungal infections are we treating in dermatology that are not fungal infection? So be very careful with that. When a nail starts looking bad and has a strange appearance, the first thing that people are going to tell you, oh, you have a fungal infection, you know? The most important thing is prove it. Make your dermatologist do a culture. If something grows, treat it. And if it doesn't disappear, you have to observe this nail. And the best way to diagnose what's going on the nails is to do what we call a nail matrix biopsy, okay? So practically, I send my patients to surgery. They do a biopsy right here, okay? Is where the nail and the cells grow. And so we can see what's really going on in this nail, okay? Not everything that happens in the nails, obviously, is bad, okay? There are very benign conditions, okay, like what we call longitudinal melanonia. It's just a nail, a pigment that grows in the nail. It's like a mole on the nail, okay? But when a patient has a longitudinal line like this, we need to follow as it would be a mole on any other part of the body, okay? We look very carefully how parallel are the lines. We put oil on the nail, we look with the dermatoscope, we see, okay, is the pigment regular, is homogeneous. We treat it like a mole, practically, okay? For example, this picture. If I have to ask you which of these is the melanoma, what would you say? The right? Well, it's the left, okay? I know, the devil never sleeps. That's the message, one of the messages today, okay? So here what we see is a very common sign. It's called the Hutchinson Sign, okay? It's pigment around the area of the skin surrounding the nail. But unfortunately, the Hutchinson Sign you can see in benign lesions and in malignant lesions. So when I was a resident, we used to hear, if you see the Hutchinson Sign, biopsy. And I still follow those norms because it can be in both, okay? But this was benign. Actually, this was a contractor that hammered the nail with at home, okay? So this was not a melanoma. This is blood under the stratum corneum, okay? We see a lot of patients that come from a big hike, say, I got a new mole on the foot, and I know already it's blood, okay? All right? Okay, the devil never sleeps. Okay, this is a ungual melanoma, okay? So observe how broad this line is. This is almost taking half of the nail, and see the pigment in the matrix here, okay? This is a very prominent Hutchinson sign, okay? Variegation of color, abnormal spacing between the bands, irregular band, abnormal parallelisms, and blurred lateral borders. That's why we look with the dermatoscope and we put oil. The eyes are not enough, okay? Avoid these in and out visits. If you are going to go to the dermatologist, and then make them spend time with you, okay? Make sure they look at you, okay? Don't go for an in and out. This is not a burger, okay? You need to be looked at head to toe, the nails, everywhere, okay? All right, and this, same thing. Patients come with these presentations. Oh, well, you know, my nail is not growing properly. Well, biopsy it. Make them biopsy it, okay? Some dermatologists, some doctors will send you home, okay? It's okay. Be on it. Follow it. Don't give up. These defects on the nails can be very dangerous, okay? So you have to be careful. All right, and this is again Hutchinson sign. I'm going to go through this, okay? So subungual melanoma accounts about 0.7 to 3% overall of melanomas. It is more prominent in Native Americans, 33%, okay? And African Americans. Has a poor prognosis because of probably delay in diagnosis between 9 and 23 months, okay? Very rare in pediatric population, okay? And histology remains the gold standard. We cannot do histology if we don't biopsy it, okay? And that's why it's very important to biopsy those lesions. Okay, and so we use also the ABCDEs for subungual melanoma, but it's different. We look at the, as I showed in the other slide, we look at how parallel are the lines, of the, if the edges are blurred, if there is a change from the beginning 2 years ago or now it's getting broader, it's getting uglier, the Hutchinson sign, etc. And the family history. Obviously, it's also very, very important the age of the patient. Most of the melanomas occur after 50-year-old. I was laughing when I saw this data. They say age range between 20 and 90. All right, so if you're 120, you don't have it, okay? All right, so, and very important is, and I want to stress that, nail plate fissuring or splitting. Take a look of the nail plates of your patients, okay, of the toes and of the hands, all right? All right, let's move on. A melanotic melanoma. If it is red and looks like a pimple and doesn't go away, it is not a pimple, okay? All right? Most of my patients, 85% of my patients are, has some Irish or Scottish in them, right? They don't even know, but when I ask it, did your grandfather have red hair? Yes. Okay, so for me, you are Scottish or Irish, okay? So this patient population doesn't have a lot of pigment. Melanomas are not going to be always brown or black, okay? Sometimes are red, they look like a pimple. Look at this, okay? I mean, well, this is, it can look even more elegant than this, very subtle color, okay? It doesn't go away, come to see us, all right? Because we have tools like a dermatoscope that we can look to other features. And I want to, sometimes you ask me, why do you look so long, you know? It's not that I fall asleep on you. I'm looking at the vessels, okay? All right? The vessels of the nevi tell us how the beast is being fed, okay? If they are pinpoint and very regular, usually it will be an intradermal nevus, which is a normal mole. If they start being very angular and corkscrewed, etc., the beast is getting the blood supply from there, okay? So we start being very suspicious, especially if it's an ugly duckling, and we will talk later about ugly ducklings, okay? All right, very subtle. It can look very subtle like this lesion here, okay? But when you look, you see these polymorph vessels, okay? This was in a melanotic melanoma. This is how it looks. See these kind of vessels? This is what we see with the dermatoscope. Again, eyes are not enough. You can see a lot with the eyes, but you need tools, okay? And that's why it's good to go to a specialist, okay? Some of them can in a very elegant, exotic manner, okay? They are brown a little bit red, so, well, you know, it's kind of inflamed, I scratch my mole, etc. Well, when you look with a dermatoscope, you see the polymorphic vessels as well, okay? Sometimes it looks like a scar. This looks like a scar, okay? But it's in a melanotic melanoma, all right? So that's why we ask so many questions when you come to the clinics. We are very nosy. We ask, okay, what did you do? What did you do last summer? Okay. Did you get highlights on your hair, right? Because if we see difference in pigment in the hair, we start being suspicious, all right? It's not that I want to know who is your stylist, okay? We want to know what's going on your scalp, okay? What's going on in your skin? Did you have an injury? Did somebody try to strangle you? Okay, probably not, but we also ask, right? Okay. All right, so a melanotic melanoma is dangerous, is commonly missed, like the ungual melanoma, okay, and like the scalp melanoma. So these three constellations of males deserve a lot of attention, okay? Very good. So you know very well how to perform a skin check. This is what I have to tell you today. Get help at home. Involve your family. Tell them, honey, look at my back. There are data that men do better because the women look at the back. Unfortunately, the data don't show yet that the men are looking at the back of the woman, all right? So I'm going to get angry if this doesn't change, okay? Look at each other, all right? Question, okay? I asked my husband, how does this look? He says, wonderful. I don't believe him, So I get my colleagues to take a look at me. He's biased, all right? All right, so ABCDs are not enough, okay? It's very good. The ABCDs are very good, okay? But they are not enough. The ugly duckling is key. What is the ugly duckling? It's a mole that looks okay, but is different than any other. It's a change on your body that comes out of the blue, and you wonder, what is this? You get this stomach pain, You sound like something is wrong. Listen to the signs. Listen to yourself, okay? When you see changes, question them. Don't say, it's okay, all right? So that's the ugly duckling. In the clinics, you see that I look at all the moles. And my residents sometimes laugh and say, well, you are overdoing it. No, I'm trying to find what's your signature. How do you pigment? Is your pigment homogeneous, or is it fishnet? Because then I write all down. So when you come to see me and I see a mole that is out of your constellation, that mole lands in the formalin bottle, as Rob was mentioning before, okay? All right? Where it cannot damage you any further, all right? All right. So everyone needs a complete skin check. It's not people with red hair, it's not the surfers. I have a wonderful surfer clinic that I love. They deserve a skin check too, but everyone deserves a skin check, okay? It's very important. Evaluate the borders, the size, and evaluate the ugly duckling, okay? All right. So, switching gears. Are you still with me? All right. What does the lab does? Okay, so we have talked this morning about immunotherapy, targeted therapy, surgical approaches, sentinel node biopsies, etc., okay? If there is a second thing that I want you to remember this morning from my talk is that biomarkers are very important in science. We talk about that the tumors get resistant to drugs. Sometimes we don't know what to start first. Are we going to start first a BRAF/MEK inhibitor because the patients have a BRAF mutation? Or are we going to start first immunotherapy? Or are we going to do the therapy first and then surgery, right? Or first surgery and then therapy? Well, how do we decide all that? The way we decide all that, or we try to decide, we are really trying to find is more biomarkers for melanoma, okay? Is there any biomarker in your tumor that is already telling us you are not going to respond to BRAF/MEK, or maybe just a couple of months, or you are not going to respond to PD-1, all right? Or is there a biomarker that tells us this weird mole that the pathologists don't know for sure that is a melanoma, it is truly a melanoma or not, okay? And that's what my lab does. Very simple say. We study biomarkers, and we study biomarkers we study what we call the epigenetic biomarkers. These are small transcripts that regulate genes, okay? They are called long non-coding RNAs, okay? And this is what we do in the lab. This is what I do when I'm not with you, all right? And I went through that already, and as Dr. Algassi was mentioning, the tumors are very, very smart, right? I mean, what do I do when I come to clinics? sometimes, unfortunately late, I get stuck in the 101 many times. Adil too, we have the same commute, so we know. Sometimes I call and say, hey, don't take this road. These are the highways and the freeways of cancer, right? This is BRAF gene. We have inhibitors to BRAF and to MEK. This is NRAS. Dr. Rassi was talking about LRAS2. These are PI3K, AKT. We have a lot of inhibitors here to cut these pathways, okay? So obviously, when you cut one, the tumor is very smart and use the other one, okay? So what we study is we take the tumors, we isolate the RNA and the DNA and try to find if there are transcripts that can tell us, okay, how the tumor is going to behave later when we start therapy or even before, okay? So long non-coding transcripts are longer than 200 nucleotides, so they are still very small, okay? And they are epigenetic regulators. What does it mean really epigenetic? Let me explain to you in a very simple manner. Epigenetic is something that changes what the gene is going to do. It's not, it doesn't get passed from one person to the other in the genes, okay? It can change because of the environment. And you are hearing a lot of things of, you maybe don't know that they are talking about epigenetic, because for example, when we say, well, we know that if you don't eat healthy, okay, you are prompt to get more cancer, for example, with higher glucose levels. So we think that this glycosylation, okay, is affecting the growth of cells and makes them grow more, okay? This is all epigenetics, okay? Environment, all right, etc. Okay, these are all epigenetics. So that you understand, only 1% of your genes make proteins. Imagine, it's amazing, okay? 99% of the DNA does something that we don't know what it is. And that's what we study. Is the regulation of the regulation, okay? These long non-coding transcripts and microRNAs regulate all the machinery of cancer and how the cells grow and everything and evolution, all right? So it's a little complicated, so I'm not going to go into whole results, but what we do is we take the RNA, we sequence it, okay, and then we have a lot of filters, okay? We have very stringent exclusion criteria. If it's in this planet, we don't want it. So if it's known, if it's in the PubMed, we don't want it. We know what it is. We take everything that looks like a long non-coding, okay? And those are the sequences that we analyze, okay? Then we have another tools to corroborate our findings, all right? And I'm just going to present some data of what we found, okay? We found so far about 291 new transcripts not described in the literature, okay? Long non-coding RNAs. And we have found some that we see in melanoma, and we don't see in benign nevi, we don't see in melanocytes, and we don't see in normal skin cells. So we think that we could be able to use them later on to diagnose the difficult cases of dysplastic mold where the pathologists don't know, shall we treat you like a melanoma and do a shark bite or not, okay? And then we found a transcript that we call it MIRAT, okay? MEK inhibitor resistant associated transcript that we only see in cells that are resistant to the MEK inhibitor, all right? And we have done a lot of experiments now. Now we are validating, actually, right now we are trying to find where this transcript is binding to. If it's binding to a protein or it's binding to a DNA, okay? We are trying to find how it works, but we know that when we inhibit this transcript, the cell growth goes down. So we know that it's important. It is important. It's making the cell resistant, okay? It's making the cell grow more under the MEK. So it's bypassing the MEK, okay? And why is that important? Well, because the MEK is used for NRAS, it's for BRAF, just for many cancers. It's also used for colon cancer, it's used for lung cancer. So here we have a cross-pollination. We have a biomarker that might help many patients, okay? So right now we are validating this data. So it's one of this data will be presented very soon in the Keystone Symposium. But just remember the word biomarker, okay? How to differentiate the good from the bad, how to know how you are going to respond, and how to modify your therapy, because these biomarkers are being constantly expressed, also when you get resistant, okay? All right, and then my lab does also nanotechnology. So we call it the super nano, and we just patent this technology, actually. So this is a molecule that has an aptamer, which is a sort of molecule that we put that makes color, okay, has a receptor, and we can put the drug in the molecule as well. So when this nanoparticle is designed to enter the cell to find a mutation and produce a color change. It's like a pregnancy test for mutations, okay? And we patent that because it's very rapid. You put the RNA on the DNA, and if it's blue, you are not pregnant, but you have maybe BRAF mutation, okay? All right? All right. And this is how it works. It gets in the cell, the pH of the cell determines that the particle opens, okay? Then our gold nanoparticle enters the nucleus, find the mutation, and release the color, okay? And that's also, we are trying to speed the process of, in the OR, to find the mutations, etc. And this, now actually the French government is very interested also to use these nanos to diagnose Ebola in Africa because it's so fast and so cheap, all right? So this, we just patented that a couple of months ago, so we are very happy. But no, I'm not leaving, okay? I'm not starting a startup or anything like that, you know. We are gonna use it for you guys. All right, so, and this is my lab. The photo didn't appear too bad, you know, because it was probably too big, okay? Where is the technology? Please help, you know, the photo is not here. Anyway, this was all my members there, you know, happily in a sunny day in San Francisco, but I guess there was too many megabytes. All right, thank you very much for being here. Thank you.